So, do you all of you can see my slide? Not yet?
Sure,
Yes,
Professor,
sir.
Doctor. It's
Yeah.
clear. It's
Clear.
quite clear enough.
Okay, thank you very much. So I would like to present about management of dyslipidemia during and after the COVID-19 pandemic. Okay, first of all, if we talk about the dyslipidemia, of course, we have to talk about the cardiovascular disease. And what is the association between COVID-19 and cardiovascular disease? Let us see. The course of disease of the COVID-19 divided into 3 stages. In acute phase, stage 1, early infection, stage 2, pulmonary phase, and the stage 3 is hyperinflammation phase. And then cardiovascular complication usually happen in the stage 3 and can be acute respiratory distress syndrome, shock, and cardiac failure. So what about the time-based? If we look at the time-based, of course, the first is exposure and then acute COVID-19. After 4 weeks, if the patient survive and then patient fall to the subacute, and then after 12 weeks, some of the patient or many of the patient, about 20% suffering from long COVID or chronic complication of COVID. And cardiac complication, especially heart complication, I mean, can be chest pain, myocardial edema, myocardial fibrosis, pericardial effusion, perimyocarditis, arrhythmia, tachycardia, and autonomic dysfunction. The cardiac or heart complication also can be occurred or can occur in the acute phase. But if the patient survive from the acute phase and then fall to the subacute and chronic phase, what is the possible mechanism of cardiovascular injury due to COVID-19? The pathophysiological effect, it might be the direct cardiotoxicity by the virus. The second is hypoxemia mediated. The third is supply-demand mismatch. And the fourth is cytokine storm to DIC. The cardiovascular manifestation can be acute coronary syndrome, arrhythmia, myocarditis, venous thromboembolism, heart failure, and or cardiogenic shock. What about the association between COVID-19 and heart failure? Especially in the long COVID or chronic phase of the COVID, heart failures can be happen caused by many mechanisms. The first mechanism, it might be caused by the inflammatory cascade, caused by the cytokine storm in the stage 3 of the acute phase, cause the myocardial injury and then heart failure. The second is microvascular dysfunction or macrovascular endothelial dysfunction and atherosclerosis, acute plaque rupture, and also cause heart failure. Other mechanism is adipokine expression, blood deoxygenation, and also cause heart failure. Finally, lung infection, make blood deoxygenation and also make inflammatory cascade cytokine and then make heart failure. So heart failure is one of the clinical manifestation, one of the important clinical manifestation in the long COVID especially. Other cardiovascular complication in the COVID-19 patient is thrombosis. And thrombosis also can be stimulated by or directly by SARS-CoV-2 infection, and then subsequently activate tissue factor pathway activation of the coagulation system, and then finally make thrombosis. So up to now, several risk factors has been identified in COVID-19 patient, especially associated with cardiovascular disease. The first is hypertension. Second, diabetes mellitus, obesity, and dyslipidemia. This data show that Kang et al. Identify that diabetes mellitus, hypertension in China, obesity in USA can be a risk factor for COVID-19 patient. And especially here, what is the risk if we compare diabetes and non-diabetes in the patient with COVID-19, hypertension and non-hypertension? What about the odds ratio? The odds ratio is quite high. Odds ratio for diabetes mellitus maybe can be 9.0, hypertension 7.3, obesity 2.7, and others. So this data show to us that diabetes mellitus, hypertension, obesity are the very important comorbid disease that associated with morbidity, mortality, severity of the patient with COVID-19. And the next question is, how about dyslipidemia? This is some data, very interesting data, that LDL and triglyceride have a different effect associated with hospital death or in intensive care unit, because in patient with COVID-19, suffering from severe COVID-19, LDL cholesterol is quite low and triglyceride is high, and the odds ratio is just only 0.61. This data look like high cholesterol protective to the COVID-19 infection. But look a minute. Zinlu and friends, et al. Also identify the total cholesterol in COVID-19 patient relatively low. Also LDL cholesterol relatively low, and also HDL cholesterol relatively low in COVID-19 patient. But is it this? The question is cholesterol is protective for COVID-19 or not? Because if in the patient with severe COVID-19, the level of cholesterol is quite low. But let us say previously that let a minute, because Wang and et al. Also identified that interestingly, he stated that interestingly, blood cholesterol was found to be lower in the most severe cases of COVID-19. But cholesterol in the monocyte from the same individual was elevated. Since we measure free cholesterol in the tissue, we expect a result similar to the blood monocyte, not zero. The high cholesterol in the monocyte is consistent with cholesterol loading into the tissue during chronic inflammation and suggests blood cholesterol may, not many, may, not always correlate with tissue cholesterol. So actually, even in the serum cholesterol of the patient or severe COVID-19 patient, low, but in the monocyte and intracell cholesterol is elevated. So it's not always correlated between the serum cholesterol and intracell or membrane, plasma membrane free cholesterol. Another data show that triglyceride has a positive correlation with CRP. That's mean triglyceride associated with inflammation. Also, triglyceride has a positive association with D-dimer. And another data that triglyceride also has a positive correlation with procalcitonin. So this data show that triglyceride look like detrimental factor for people who suffering from COVID-19. Another topic that we have to discuss, interesting topic, is since dyslipidemia can be a risk factor for patients with COVID-19, the question is, how can we manage dyslipidemia in patients with COVID-19? Of course, we have to see guideline first about the use of statin and other drugs for patients with dyslipidemia. Look at the European Society of Cardiology in 2019 published guidelines. And this guideline shows or stated about in the very high cardiovascular complication or cardiovascular disease, we have to lower cholesterol as much as possible until up to 55 milligram per deciliter. But this is a general guideline. The question is COVID-19 categorized at a very high cardiovascular risk or not? Up to now, there is not clear yet. But in my opinion, COVID-19 is a risk for very high, including a very high cardiovascular complication. So in the patient with COVID-19, we have to lower cholesterol as much as possible. But of course, from the individual, for some individual, several individuals, we have to consider about the side effect of drug for cholesterol, lowering cholesterol. So what kind of drugs that's recommended? We know that statin is the first and what's that? The widely used to lowering cholesterol and to achieve the target of LDL-C. If the goal is not achieved, of course we able to add another statin lowering drug like ezetimibe or PCSK9 inhibitor. Statin is the drug of choice because statin, in COVID-19 patient has been identified by Tan et al. That statin has a LDL cholesterol lowering effect, a good LDL cholesterol lowering effect. And the effect of statin associated with LDL cholesterol will decrease cholesterol in cell membrane, decrease intracellular cholesterol, and finally decrease ACE2 receptor. Another effect of statin, a very good effect of statin, is beyond LDL cholesterol lowering effect or pleiotropic effect, because statin has anti-inflammatory effect and also immune modulatory effect. This this statement supported by data that also identified by Wu et al. That the association between statin use and the need for intensive care unit, the odds ratio, if we compare the patient with statin use compared with the patient who didn't use a statin, the odds ratio is 0.29. That means that statin good to prevent, yeah, prevent to patient go to the intensive care unit. Another data is the association between statin and the need for invasive mechanical ventilator support, and also we identify, we have a data that the odds ratio just only 0.8. Another data is the association between statin and mortality. And again, we have data that statin is a protective factor to mortality, in COVID-19 patient with odds ratio 0.7. That's give us a summary based on the data that we have previously presented, that dyslipidemia is a risk factor for morbidity and mortality of patients with SARS-CoV-2 viral infection during acute and chronic phase or long COVID. The second is high cholesterol, especially membrane and interstitial cholesterol, is associated with increase of binding, entering virus to the cell by lipid content raft entering virus to the cell, and also replication of SARS-CoV-2 virus, because once virus go to the internal of the cells and then they replicate, and they need cholesterol to replication. And the third is high triglyceride is associated with inflammation process in COVID-19. So triglyceride is a detrimental factor for patients who are suffering from COVID. And finally, the last is statin decrease morbidity, severity, and mortality in patients with SARS-CoV-2 infection. That's the data. Unfortunately, we have no data in Indonesia, and up to now, many study still ongoing to identify another drug for lowering cholesterol, for lowering triglyceride, but up to now the result hasn't come yet. Not already provided. Yeah, I think Mr. Shoni, this is something that I would like can be share to the audience. Thank you very much for the chance. Thank you.